The greatest risk with IVF was ovarian hyperstimulation. In the oocyte retrieval, we use a 17 gauge needle. Most of those times they're going to be transvaginal. So there are small risks of bleeding, infection, injury to organs. The ovaries are enlarged after the retrieval, and so there is an increased risk of adnexal torsion in these patients. The good news is that the risks with ART are declining. So ovarian hyperstimulation is related to ascites, and then the patients become intravascularly depleted. One mechanism is through VEGF. Typically, it's detectable about 5 days after the oocyte retrieval, and if the patient's not pregnant, resolves by the next menses. Because it's usually detectable by 5 days, if the patient still desires an embryo transfer and may be at risk, I'll do an ultrasound on the day of the embryo transfer. If there's evidence of ascites, we are more likely to freeze all of our embryos. Risks with this are going to be thromboembolic phenomenon due to being intravascularly depleted, electrolyte abnormalities, hyperkalemia, hyponatremia, and then end organ failure, liver and kidney failure. The risk factors for hyperstimulation are mainly related to the number of eggs. If the patient becomes pregnant, it continues. And so it's related to the ovulation. If the patient has an LH surge or if the patient receives HCG. Since HCG has a longer half-life, it will continue longer. If the patient freezes all of her embryos and does not become pregnant, it's going to resolve relatively soon. If she becomes pregnant, it will be longer. There are a number of strategies to reduce the risk of ovarian hyperstimulation. We'll monitor cycles with ultrasound and estrogen. Again, we're looking for high number of oocytes over 25, estrogen levels over 3,000. And then if we determine that they may be at increased risk, we have strategies to lower those risks. You can't say it's completely eliminated the risk of ovarian hyperstimulation, but we rarely see it anymore with these strategies. So we know preterm birth is one of the largest contributors to perinatal morbidity and mortality. And it's been well established that IVF is associated with preterm birth and low birth weight. These risks have been decreasing, and they had noted a decrease in preterm birth, very preterm birth, low birth weight, very low birth weight, and stillbirths. And they concluded in the study that the beneficial effects were mainly due to the increase in single embryo transfer and lower rates of multiple gestation. The identical twinning hasn't been able to really be eliminated with a blastocyst transfers. The things that we have tried to do to lower this risk is we've been the use of soft catheters, rounded edges, slowly placing the embryo in the catheter and slowly placing the embryo into the uterus to reduce shearing forces. But it still remains higher. It may be around 2 to 3% chance of identical twinning for a blastocyst compared to natural risks out of day 3. We do know that even on day 3, that if we do ICSI, where we put the sperm through the zona, or if we do hatching, we might be increasing the rate of identical twinning at this time because of allowing the embryo to hatch. One of the variables that you have in the CDC data is the etiology of infertility, suggesting that preterm birth, low birth weight may be related to the etiology of the infertility, not necessarily the procedure itself. We looked at the CDC data for the etiology of the infertility, and what we found was that birth weight less than 2,500 grams was increased in patients with tubal factor, uterine disorders, and ovulatory disorders. And we know that there's an increased risk of miscarriage for tubal disorders, and that treatment will lower it. Miscarriage has also been tied to diminished ovarian reserve, so patients with low AMH, elevated FSH, low AFC. So miscarriage and PCOS, patients might have a higher risk of miscarriage. Some of this is thought to be due to the presence of hyperinsulinemia, which causes progesterone resistance. There may be factors as far as obesity and inflammation and higher rates of loss in patients with PCOS. Birth defects affecting about 1 in 33 in the U.S., high rate of cause and leading cause of infant mortality. This is, our National Society's summary on birth defects is naturally it's about 4%, 3% for severe defects. Assisted reproductive technology, it's about 5%, 3.7% for severe birth defects. And most of the increased risk is due to the older age, aneuploidy, the etiology of the subfertility, particularly oligospermia and multiple gestation. The worse the infertility is, the higher the rates of birth defects, probably because that the underlying etiology of infertility worsens. For example, that the sperm count's decreasing, and so the lower the sperm count, the more likely they need to use IUI, and if it's even lower, the more likely they are to use fixing. We know that patients with infertility have an increased risk of breast, ovarian, and uterine cancer. There are a number of confounding variables such as nulliparity, late age at first birth, the length of use of hormonal contraception and ovulation, and the use of imaging for detection. As far as the infertility and cancer, most of the recent studies show that the risk is related to the confounding variables such as the nulliparity. There may be an increased risk for borderline tumors. It hasn't been associated with a particular fertility medication, and the incidence is fairly low. The fallopian tube is a potential source of ovarian cancer, needs to be evaluated. And in the past, it was thought that the fertility drugs role in ovarian cancer was due to incessant ovulation, but in light of the fact that most cancers are coming from the femoral end of the tubes, that it's not likely related to number of ovulations. There have been a number of databases that have shown an increased chance of cancers in children born from assisted reproductive technology, but the studies have varied. The numbers are really low, so when you have large numbers of patients in the studies, small differences become statistically significant. In addition, the types of cancers have varied, so that it questions whether or not that it is real. And then also many of these databases cannot control because it's not included in there as far as their etiology of infertility or subfertility. For the imprinting disorders, the studies don't agree on whether disorders are associated with IVF or not. These disorders are fairly rare, maybe 1 out of 1,500 people. And then they may be associated with subfertility and oligospermia, not necessarily the IVF and the culture techniques. The risks of assisted reproductive technologies are declining mainly due to the decrease in ovarian hyperstimulation and the increase in the use of elective single embryo transfer. Birth defects, preterm birth, low birth weight, and cancers may be related to the etiology of the infertility and the confounding variables such as age. As far as the childhood cancers and imprinting disorders, they're rare, and they don't all agree on whether or not they're related to assisted reproductive technology. And on the cancers in women, it's related to their infertility etiology, but there may be a slightly higher risk of borderline tumors in patients with infertility. And so it's not been tied to necessarily a particular type of treatment. Some of the studies have suggested that increased length of therapy, 6 cycles to 12 cycles, might contribute to that risk. Since most people conceive within 3 to 6 cycles of a fertility treatment, because of that potential association, it's better not to continue with fertility medications if it's not likely to be successful.